Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure today to present to you this topic as part of BIC rotation entitled of a cardiopulmonary interaction, basic and clinical implication. This topic one of the fundamental topic in pediatric intensive care unit. I'm going to cover this objective in this session. By the end, I hope you will understand the effect of ventilation on circulation, mainly the venous retain and pulmonary circulation, and then the effect of ventilation on the left ventricle. And throughout the presentation, I'm going to give some clinical implication of this basic knowledge. So let's start our talk by the cardiac effect of normal respiratory cycle. So you know during inspiration, there will be a negative intrathoracic pressure in order to the air to flow from atmosphere into the lung. And this negative intrathoracic pressure will result in stretching effect on the right ventricle, mainly, not the left ventricle. And this is because the right ventricle actually have a thin wall that allow more stretching compared to the left ventricle. This stretching of the right ventricle will result actually in reduction in the pressure in the right side of the heart, and that's why there will be a venous retain. Because also stretching of the pulmonary vessels during inspiration, there will be no much retain of blood to the left side, and this will result in reduction in the stroke volume in the left side. This reduction in stroke volume will result in reducing of blood pressure. Okay, so this phenomena is known as pulsus paradoxus. So usually during inspiratory process, there will be a reduction of blood pressure by 10 milli of mercury, and this phenomenon we call it pulsus paradoxus, which can be exacerbated in different clinical condition like an asthma or the cardiac tamponade. So what will happen to the heart rate? So heart rate actually during inspiratory process, there will be a reduction, there will be increase in the heart rate, and this can be explained by two things. The first thing is because it's a reflex to the hypotension that occurred, and the second important pathophysiology for that is actually during inspiratory process there will be a stimulation of the afferent nerve of the vagus nerve that is occur in the lung, and that will result in the inhibition of vagal tone, and inhibition of vagal tone, as you know, it's a result in tachycardia. So let's sum up what's happened during inspiratory process. There will be reducing of the heart rate by 10 of mercury, and this we call it pulsus paradoxus. The heart rate on the other side will increase, and this is because of inhibitory effect to the vagal tone and as a reflex for the reducing of the blood pressure. So the opposite will happen actually during the expiratory phase. So during expiratory phase, there will be increase the intrathoracic pressure, and that increase in the intrathoracic pressure will result in somehow a compression effect on the pulmonary vein, and that compression effect will result in increased drug volume to the left side, and increasing the flow to the left side will result in increased drug volume. Increased drug volume will result in increase in the blood pressure. However, opposite will happen to the heart rate, in which there will be a decrease actually in the heart rate because of the stimulation of the vagus nerve. So further stimulation of vagus nerve will enhance the negative tone effect of the vagus nerve and will result in somehow bradycardia. And the difference between the two part of the respiratory cycle, the inspiratory phase and expiratory phase, will result in change in the ECG. We call it the sinus dysrhythmia, which is basically happen because there will be this change in the vagal tone during the inspiratory and expiratory process. After this small introduction to the normal respiratory cycle effect or the cardiac effect on the normal respiratory cycle, let's go to the main objective in our presentation, which is one of the main objectives, which is the venous retain. So venous retain, basically there will be, it's a form of flow. So in order to have a flow, you need to have two pressure difference, and we are talking here about the pressure, the systemic venous pressure, okay, and the right ventricle pressure. So when there is the mean systemic pressure is the pressure when the vein there is no flow occurred in the vein, and it's governed by two factors. The first one is the volume status, and the second thing is actually the venous capacities, and the venous capacitation or the compliance of the wall itself. So if you have hypovolemia, for instance, this systemic pressure will be reduced and there will be no much venous return. And if you have something affecting the venous wall compliance, then that also will affect your venous return. And this is something, let's take an example of it, is the effect of, for example, phosphate diesterase inhibitor. Those drugs actually will result in relaxation of the wall of venous wall, and that relaxation will result in decreased compliance, which will result in decrease in the venous return. In this graph, I'm trying to show you the effect of venous return on the cardiac output. So in this here, we have the cardiac output, and in the x-axis we have the central venous pressure. So you can see if there is like increase in the central venous pressure, which is actually right, somehow correlating to the right arterial pressure, there will be an increase of the cardiac output up to some extent. However, increase in the systemic central venous pressure or the right ventricular pressure, meaning there will be no much flow between the systemic venous pressure and the right ventricle, and there will be no much of venous return, and that's why the cardiac output after which will be static. To sum up this graph, you can see that the venous return will increase the cardiac output. However, because at some extent the right ventricular pressure will be increasing and doesn't allow further flow, there will be a static cardiac output. So increased venous return will increase cardiac output. This is Frank-Starling law. However, after extent of increasing the right ventricular blood pressure, there will be no much flow and the cardiac output will be static. So central venous pressure is an equivalent to the right atrium pressure in the absence of severe venous cave obstruction. And there are how to measure it and what to determine the central venous pressure that I'm going to explain in this slide. So a central venous pressure is a functional measure of the right arterial pressure and the gastocardiac pressure. Okay, and it's determined by the venous compliance and by venous return, and as we explained in the previous slide. How to measure it? There are two main ways to measure the central venous pressure. The first one is by direct catheter guide. So you insert a catheter in the internal jugular vein or subclavian vein, and this catheter tip, it should be horizontal to the tricuspid valve, and at the end of the severe vein, at the beginning of the severe vena cava. Another way to measure it is non-invasive by the ultrasound, is to find the inferior vena cava pressure at the level of the formation of the inferior vena cava, where the hepatic vein meet with the portal vein to form the inferior vena cava. If the width there is more than 2 cm, we call this increased central venous pressure. However, if the width is actually less than 2 cm, then we can say this is decreased in the central venous pressure. Another important things about central venous pressure, it's like used to guide the fluid status of the patient, volume status of the patient, and whether we need to give a bolus or not. So reducing the central venous pressure to some extent will give you a picture about the volume status of the patient. So now let's see the effect of positive pressure ventilation on the venous return. So you know, when we apply a positive pressure like high or beep in patient with ventilation, this will result actually in creating increased intrathoracic pressure, and that will compress the right atrium, and the compression of right atrium will result in increase in the right atrial pressure, and meaning there will be decrease in venous return, and as venous return decrease, there will be decreased right ventricular volume. So this effect will be more obvious in a patient who already hypovolemic or depleted, or those who are right-sided dependent. I will see in coming slide how that gonna affect them. But if you have, for example, a hypovolemic patient and you apply a ventilation with higher positive pressure ventilation, then those patients, their hypotension can deteriorate further because of reducing right ventricular stroke volume. And a patient who has like a right-sided dependent heart failure, their heart failure will be exacerbating by giving them higher beep. So let's now move to talk about the effect of ventilation in pulmonary circulation. And to understand that, we need to know some basic about pulmonary circulation. So what's determined actually pulmonary venous resistance is the resistance over two types of pulmonary vessels. The first type of pulmonary vessels, we name it as the septal vessels. The second type of pulmonary vessels is the corner vessels. So when you have like overstretching of the lung, those septal vessels will be compromised and their resistance will increase. So if you increase toward the total lung capacity or overextension of the lung, there'll be increase in the pulmonary vascular resistance because compression of the septal vessels. And when you have like deep expiration, okay, and shrinking of the lung toward the right residual volume, then the corner vessels will be compromised, and this will result in the increased pulmonary resistance. And that's why the best time to maintain like the narrow pulmonary vascular resistance is to maintain toward the tidal volume. And you know, during tidal volume there will be a functional residual capacity. So you want a beep that give you around tidal volume, so there'll be no much compression toward the septal vessels and no much compression toward the corner vessels. Okay, this graph, I'm just like remind you about the functional capacities and other volume flow of the lung. So, and this can explain how high beep could cause hypoxia. So if you give higher beep, that will result in overdistension of the normal alveoli, which will result in compression of the septal vessels, and subsequently will result in ventilation perfusion mismatch and shunting of blood flow from normally ventilated lung toward area of consolidation, which will result actually in further hypoxia. Another important determinant of the pulmonary circulation is the gravity. So you know there is something called the west zone, and west zone actually divided the lung into three zones: zone 1, zone 2, and zone 3. In the zone 1 there will be more air comparing to the blood flow, and this will give you ventilation perfusion mismatch, and it is like acting like a dead space where there will be ventilation but no much of exchange of the gas because there will be no much of blood flow, comparing to the zone 3 where there will be more blood flow but less aeration, and again there will be ventilation perfusion mismatch, and this time it will act like intrapulmonary shunting effect. So the best zone is zone 2 where there will be more of like an equivalent air entries and ventilation compared to the blood flow. Oxygenation compared to the blood flow, where the ventilation perfusion will equal around 1. And this effect is important also in a patient, for example, in proning process, where we are trying to overcome the effect of gravity in pulmonary circulation and enhance the oxygenation process of the patient. This is graph trying to show you the third effect of ventilation process. The third effect determinant of the pulmonary circulation, which is the effect of gas hypoxia and pH on oxygen and CO2 on pulmonary circulation. As the graph trying to show you, if you have acidosis, there will be more vascular resistance in the pulmonary circulation. So if you have higher amount of CO2, there'll be more acidosis, respiratory acidosis, which will result in more vascular resistance. If you have, for example, hypoxia, it's also resulting in what? In higher resistance. So in order to manage patients, for example, with pulmonary hypertension crisis, we give higher amount of oxygen, hyperoxia, and we try to avoid acidosis by washing out of CO2 and to keep the patient to alkalotic site. And this is what actually the ventilation do. So the ventilation will give some control in respiratory washing of CO2, by which you can actually reduce the acidosis, and that will result in reduction in the pulmonary resistance, and we give oxygen that will improve the vascular resistance. So we have talked about the major determinant of pulmonary vascular resistance, naming the gravity, the acidosis and oxygenation, and high amount of CO2, and we also talk about the overdistension of the lung and shrinking effect. Now let's talk about the effect of ventilation of the left ventricle. What make the left ventricle unique is what we have explained earlier in this presentation, is the muscle wall thickness that does not allow the pressure transmission like toward the right side. And here the ventilation also play an important positive pressure ventilation play an important role in the left ventricle. So let's try to understand that by those 4 scenarios. The first scenario, in which I'm trying to show you, there will be a negative pressure in case of normal respiratory cycle. So a negative intrathoracic pressure doesn't change much to the cardiac output of the left side, because there is no much difference in the pressure. However, if you take exacerbated inspiration, like in case, for example, of croup, be more negative pressure, and that more negative pressure will result in an increase in the afterload. Okay. However, if you apply a positive pressure, there will be a difference between the intra-aortic, the intraventricular pressure and the intrathoracic pressure will be around 80, and this will result in somehow reduced afterload and capabilities of the left ventricle to push blood. However, in the 4th scenario, we'll be having vasodilator effect. So vasodilator will result in the reduction in the intra-aortic pressure, and that reduction actually will help the left ventricle to pump the blood. So the effect of positive ventilation pressure, it's helping the left ventricle to overcome the pressure gradient, and this is what we have to overcome the afterload. Okay, in another simple term. So now let's see the effect of positive pressure ventilation in case of left-sided heart failure, for example? It's actually improved the left-sided heart failure by three main ways. The first way, it decreased the right ventricle stroke volume, as we explained in the previous slide, and that will reduce the left ventricular preload, so no much blood will overflow to the left side, and that will result in relaxing of the left ventricle. Another things which we explained also in the previous slide, it will reduce the afterload, and by doing so, it will help the left ventricle muscle to pump easier against the resistance. The third thing, it will also decrease the metabolic demand of work by providing oxygenation and increasing the coronary artery blood flow. So simply, those patients who have left ventricle failure, they will benefit from positive pressure ventilation. In this slide, actually, I'm trying to wrap up the effect of positive pressure ventilation in the right side and left side. And you can see the cardiac output of the two sides will be actually determined by the underlying condition. For example, if a patient who has right-sided dependent heart failure, if you give them higher pressure ventilation, then their condition might deteriorate. An example is tetralogy of Fallot. So patients with tetralogy of Fallot might not tolerate positive pressure ventilation because they are right-sided dependent. However, if you have patient who is having left ventricular failure, their cardiac output improve after giving them positive pressure ventilation. Another clinical implication of the positive pressure ventilation is actually something called pulse pressure and stroke volume variabilities. So during inspiratory and expiratory process, there will be some variabilities in stroke volume. However, this exacerbation shouldn't be reaching 5 to 15%. If do so, then this might indicate hypovolemic status. I'm not going to details because there'll be a specific condition when you can apply this to clinical practice. So take home message. Basic understanding of cardiopulmonary interaction is a fundamental aspect in management of ventilated patient, and you need to be aware about different scenarios when you apply the positive pressure ventilation to the patient and whether it might benefit the patient or cause more harm. That's all to tell you about in this presentation. I hope it met your expectation, and see you in another presentation. My regards, and this is my reference. Thanks a lot for your hearing.